Hi, everybody. This is Jeanne E. Poole. I am the editor-in-chief of the Heart Rhythm O2 Journal. This is the December podcast. We have quite a long lineup of really great papers, and the first paper, the title is Differential Inflammatory and Myocardial Biomarker Response After Pulsed Field Ablation for Atrial Fibrillation Using Balloon in Basket versus Pentaspline Catheters by first author Jan Per Wenzel. The first key point is both balloon in basket and pentaspline pulsed field ablation catheters induced significant elevations in inflammatory and myocardial biomarkers after pulmonary vein isolation. Second, the pentaspline catheter was associated with a more pronounced inflammatory response with significantly greater increases in leukocytes and a trend toward higher C-reactive protein levels compared with the balloon in basket catheter. The balloon in basket catheter showed significantly higher creatinine kinase elevations, suggesting differences in mechanical interaction and myocardial impact. And finally, renal function remained stable in the balloon in the basket group, but significantly declined in the pentaspline group, indicating distinct systemic effects between catheter designs. The title of the next paper is Atrial Fibrillation Laser Balloon Ablation Multicenter International Study by Dr. Christian Martignani and colleagues. First key finding is, in a large real-world registry of 427 patients, laser balloon ablation demonstrated a favorable safety profile, including a 0.2% rate of permanent phrenic nerve palsy, and also achieved a 12-month arrhythmia-free survival of 73.8% off antiarrhythmic drugs. Second, success at 12 months is independently predicted by three key factors: the patient's clinical status, presence of congestive heart failure, the patient's unique anatomy, presence of pulmonary vein variants, and the operator's procedural experience, being within the learning curve. Third, congestive heart failure is an independent predictor of recurrence with a hazard ratio of 2.04. It signifies a more advanced atrial cardiomyopathy where pulmonary vein isolation alone may be insufficient for long-term rhythm control. This highlights the importance of managing comorbidities and selecting the ablation technology in relation to the patient's clinical profile. Next, complex pulmonary vein anatomy is not only a technical challenge, but also an independent predictor of long-term arrhythmia recurrence with a hazard ratio of 1.79, highlighting the importance of anatomic assessment in risk stratification. And finally, operator experience has a critical and quantifiable impact on outcomes. Procedures performed beyond the first 15 institutional cases were independently associated with a significantly higher rate of 12-month success. The title of the next paper is Utility of Omnipolar Mapping Guided Cable Tricuspid Isthmus Block by Dr. Hideyuki Hasabi and colleagues. The first key finding is omnipolar technology can visualize the activation vector, a critical conduction site that is atrial activation focusing sites, or AAFS, in the cable tricuspid isthmus. Could be identified in most patients using omnipolar technology. A block line in the CTI was completed by radiofrequency applications at the AAFSs, and a continuous linear lesion was not necessary among patients in whom AAFSs were identified. Omnipolar mapping during program pacing was useful to identify AAFSs in patients in whom sustained atrial flutter could not be induced. The title of the next paper is Early versus Delayed Ablation for New-Onset Atrial Fibrillation, 5-Year Real-World Data Outcomes by Dr. Jacob Heath and colleagues. First key finding is early ablation therapy for atrial fibrillation, ideally within the first year from diagnosis onset, leads to improved normal rhythm at 3 and 5 years of follow-up. Next, diagnosis to ablation within 1 year of diagnosis leads to decreased incidence of heart failure exacerbation, ischemic stroke, hospitalization, and mortality. Third, the overall benefits of early ablation therapy are seen independent of the type of AF a patient develops. And finally, ablation therapy warrants early discussion for patients and should be considered in conjunction with or even before other medical treatments of AF. The next paper is titled Electrophysiological Outcomes of radiofrequency ablation for supraventricular tachycardias in patients with CCTGA by Dr. Toshihiro Nakamura. The first key finding is that catheter ablation for supraventricular tachycardias in patients with congenitally corrected transposition of the great arteries, or CCTGA, was technically feasible and yielded favorable acute procedural success. Despite the complexity of congenital anatomy and surgical alterations, ablation provided meaningful arrhythmia control in most cases. Second, the type of prior surgical repair strongly influenced arrhythmia presentation and ablation outcomes. Patients with anatomical repair underwent ablation at a younger age, whereas physiologic repair and non-surgical groups were generally older. Next, ablation targeting the cable mitral isthmus proved to be an effective strategy in CCTGA patients, particularly for atrial flutter circuits involving the mitral annulus. CMI ablation contributed to durable rhythm control and may be considered a cornerstone technique in the ablation of supraventricular tachycardias and CCTGA. Up next is a paper titled Epicardial Adipose Tissue and Ablation Outcomes in Obese Patients with Paroxysmal Atrial Fibrillation, a comparison of pulsed field and radiofrequency ablation by Dr. Florian Englert and colleagues. First key finding: photon counting computed tomography enabled precise volumetric quantification of left and right atrial epicardial adipose tissue in all patients. Second, recurrence rates were lower after pulsed field ablation than high-power, short-duration radiofrequency, 17.1 versus 33.9% at 1 year. Third, left atrial EAT volume was an independent predictor of arrhythmia recurrence after PFA, with hazard ratio 1.06 and 95% confidence intervals between 1.01 and 1.12, p-value of 0.022. And finally, in the radiofrequency group, EAT volume showed no significant association with recurrence. Next is a paper titled Differential Subclinical Hemolysis After Pulsed Field Ablation Using the FHRS Pentaspline Catheter versus the Pulse Select Circular Multi-Electrode Array Catheter by Dr. Sayana Kuraoka and colleagues. First key finding: pulsed field ablation with a Pulse Select Circular Multi-Electrode Catheter resulted in only mild subclinical hemolysis, comparable with Farapulse despite the absence of a procedural limit on the number of applications. Second, unlike Farapulse, Pulse Select showed no correlation between the number of applications and post-procedural free plasma hemoglobin levels, suggesting a favorable safety profile even for extended lesion sets. Next, no cases of acute kidney injury occurred in any group, and renal function remained stable under a standardized pre- and post-procedural hydration protocol, with normal saline at 1 milliliter per kilogram per hour. Finally, the Pulse Select system may be safely and flexibly applied for pulmonary vein isolation and additional ablation targets without increasing the risk of clinically significant hemolysis. Next up is a paper titled Assessment of Incomplete Lesions Using Three-Dimensional Mapping Following Pentaspline Pulsed Field Ablation for Atrial Fibrillation by Dr. Atsuhiko Yagashita and colleagues. First key finding is that systematic post-ablation three-dimensional mapping revealed residual conduction in 16% of patients undergoing pulmonary vein isolation for paroxysmal atrial fibrillation and 48% undergoing PVI, one posterior wall isolation for persistent AF, despite standard procedural guidance based primarily on fluoroscopy. Detection rates did not significantly decline over case quartiles, suggesting minimal impact of the operator learning curve. Second, gaps were most frequently located at the right inferior pulmonary vein and mid to inferior posterior wall, anatomically challenging regions where catheter stability and tissue contact are variable, highlighting the limitations of conventional guidance in ensuring complete lesion formation. Third, targeted touch-up ablation at these sites resulted in acute electrical isolation and was associated with low early to midterm AF atrial tachycardia recurrence rates, supporting the integration of 3D mapping into ablation workflows to improve procedural durability, especially for anatomically complex substrates. Next up is a paper titled High-Amplitude Pacing Can Identify Epicardial Connections in the Posterior Wall During Ablation for Atrial Fibrillation by Dr. Arshad Muhammad Iqbal and colleagues. First key finding is that high-amplitude pacing identified possible epicardial connections in 63% of patients undergoing posterior wall isolation for persistent atrial fibrillation. PWI was achieved in 80.9% of patients with HAP-only capture after additional ablation compared with 100% in patients with HAP capture or with exit block. Next, mid-posterior wall regions showed the highest frequency of HAP-only captures, aligning with known epicardial conduction pathways. Next, overall atrial fibrillation recurrence was 30%, but recurrence was significantly higher, 43%, in patients with persistent HAP capture than 10% in patients with HAP capture with exit block. Next, persistent HAP-only capture without exit block remained in 19% of patients despite extensive additional ablation, suggesting that some epicardial connections are resistant to standard endocardial techniques. Finally, the study highlights the utility of HAP in unmasking epicardial connections that may otherwise be missed, potentially improving the durability of PWI and long-term outcomes after ablation. Next up is a paper titled The Usefulness of Catheter Ablation Even in Patients with Myocardial Impairment. Myocardial extracellular volume assessed by pre-ablation planning computed tomography cannot predict atrial fibrillation recurrence, by Dr. Yuichiro Surata. First key finding, left ventricular extracellular volume, or ECV, quantified by pre-ablation planning computed tomography could not predict atrial fibrillation recurrence after catheter ablation, with emphasis on pulmonary vein isolation. Second, when patients with AF were divided into two groups by CT ECV median values of 28, 35, 40, 50, and 60%, no significant difference in AF recurrence was observed after catheter ablation between high and low CT ECV groups. Finally, these findings suggest that regardless of the extent of the left ventricular damage, the elimination of AF triggers is critical for maintaining sinus rhythm. The next paper is titled Clonal Hematopoiesis of Indeterminate Potential as a Risk Factor for Atrial Fibrillation. Evidence of a Causal Relationship by Mendelian Randomization Study by Dr. King Zhang and colleagues. First key finding is that Mendelian randomization analyses using two large independent atrial fibrillation genome-wide association studies demonstrated a significant but relatively modest causal association between clonal hematopoiesis of indeterminate potential, CHIP, and increased AF risk, both for overall CHIP with an odds ratio of 1.06 and for specific driver mutations, including DNMT3A CHIP and TET2 CHIP. Next, there was no evidence supporting a reverse causal effect of AF on CHIP, including DNMT3A and TET2 mutated CHIP. Finally, elevated blood pressure, particularly systolic blood pressure, was identified as a mediator in the DNMT3A CHIP-associated risk of atrial fibrillation. Next up is a paper titled Long-Term Outcomes of Upgrading to Cardiac Resynchronization Therapy in Patients with Left Bundle Branch Block or Right Ventricular Pacing by Dr. Yoshitaka Oshima and colleagues. First key finding is in patients undergoing cardiac resynchronization therapy, the risk of all-cause mortality or heart failure hospitalization was higher in the upgrade group, left bundle branch block or right ventricular pacing, than in the de novo CRT group with left bundle branch block. Next, in the upgrade group, left atrial diameter was associated with a higher risk of all-cause mortality or heart failure hospitalization. And finally, in the upgrade group, left atrial dimension was a negative predictor of CRT response. Next is a paper titled Plasma Chile, a prospective, multicenter, observational cohort study of patients with heart failure and reduced left ventricular ejection fraction by Dr. Ruben Aguayo and colleagues. In Chile, a high proportion of patients with heart failure had arrhythmic risk factors such as atrial arrhythmias and conduction disorders. Second, the pharmacological treatment for these patients was consistent with the 2017 American College of Cardiology and AHA Heart Rhythm Society recommendations. Next, only 34.4% of patients who required a cardiac implantable electronic device had one at baseline, and just 33.3% of those eligible received ICDs or CRT defibrillators or its upgrade within a year, indicating a gap in adherence to the Class 1 recommendations of the 2017 guidelines. Finally, the underutilization of CIEDs was largely attributed to challenges in access and care coordination. Next is a paper titled Pacing-Induced Cardiomyopathy Following Leadless and Transvenous Pacemaker Implantation, a multicenter retrospective study by Dr. Kevin Lee and colleagues. First key finding, there's no significant difference in pacing-induced cardiomyopathy rates between patients receiving leadless pacemakers and patients receiving transvenous pacemakers. Second, prolonged paced QRS is a predictor of pacemaker-mediated cardiomyopathy. And finally, higher pre-implant left ventricular ejection fraction is protected against the development of pacing-induced cardiomyopathy. The title of the next paper is Safety of Bioelectrical Impedance Analysis in Patients with Cardiac Implantable Electronic Devices, a systematic review by Dr. Leonardo Uribe-Cavero and colleagues. First key finding is that clinical-grade bioelectrical impedance analysis showed no electromagnetic interference, malfunctions, or induced arrhythmias in cardiac implantable electronic device recipients. Device parameters remained stable. Second, continuous telemetry electrogram revealed no oversensing or pacing inhibition during bioelectrical impedance analysis. Next, a small subset had same-day arrhythmias without telemetry changes, suggesting non-BIA causes. And finally, heterogeneity limits certainty. Protocol standardization is required and results do not generalize to consumer wearables. The title of the next paper is Real-World Outcomes of Left Atrial Appendage Closure in Very Elderly Compared with Younger Patients by Dr. Adam Moman-Borkowski and colleagues. First key finding is that implantation of LAAO is as safe as effective in the very elderly patients as in the younger patients. Second, there is a trend toward increased one-year mortality in the very elderly. And finally, the utility of LAAO implantation should be considered in the very elderly patients. The next paper is titled Near-Zero Fluoroscopy Pulsed Field Ablation Using the Circular-Shaped Catheter with ICE-Guided Real-Time Fifth Electrovisualization, the FOCUS Technique, by Dr. Shintaro Yamagami and colleagues. The first key finding is that near-zero fluoroscopy pulsed field ablation guided by intracardiac echocardiography and three-dimensional electroanatomic mapping using the fifth electrode-oriented contact under SoundStar technology was feasible. The mean fluoroscopy time was 3.4 plus or minus 2.4 seconds. 3 of 10 cases were performed with zero fluoroscopy. Next, continuous ICE fan alignment to the fifth electrode enabled reliable catheter tissue contact assessment without contact force sensing and supported complete acute pulmonary vein isolation in all 10 patients with no complications. Third, the workflow was reproducible under deep sedation, incorporating standardized ICE views for each pulmonary vein and over-the-wire guidance. The mean left atrial dwell time was 38.0 plus or minus 4.9 minutes. And finally, short-term outcomes were favorable. At 6 months follow-up, no atrial arrhythmia recurrence was documented in any patient, although longer-term durability remains to be established. The title of the next paper is High Impedance Alert in a Hybrid Pacemaker System by Dr. Siddharth Agarwal and colleagues. First key finding is that lead connector interface issues such as oxidation or microscarring can cause transient high impedance in hybrid pacemaker systems. Second, Boston Scientific pacemakers with Abbott or Medtronic leads are prone to high impedance owing to terminal ring oxidation and movement. Third, reprogramming hybrid pacemakers to bipolar sensing or unipolar pacing can prevent safety switching and avoid unnecessary lead extraction for connector issues. Next up is a paper titled Prediction of Cardiac Resynchronization Therapy Super Response by Left Bundle Branch Area Pacing Using an Artificial Intelligence-Enabled Electrocardiogram by Dr. Zaiki Liu and colleagues. First key finding is that left bundle branch area pacing is highly effective in delivering CRT therapy. Second, a high proportion of super responders, 54%, was observed among patients who underwent left bundle branch area pacing for CRT. Third, the artificial intelligence-enabled electrocardiogram showed high specificity, 92%, in predicting CRT super response when a large reduction equal to or greater than 60% in predicted low ejection fraction probability was observed after left bundle branch area pacing. Next, the paper is titled Pulsed Field Ablation and Device-Device Procedural Interactions with Cardiac Implantable Electronic Devices by Dr. Carolo Abdelsayed and colleagues. First key finding is pulsed field ablation was misidentified by cardiac implantable electronic devices as ventricular events. Second, the misidentified ventricular events differed among normal ventricular beats, ventricular tachycardia, and ventricular fibrillation. Third, a loss of atrial capture was found in the atrial lead when PFA was applied close to it. Finally, no changes in device parameters were observed after the procedure. The next paper is titled Atrial Electrogram Differences Between the Dual Energy Ablation Catheters and a Conventional Mapping Catheter by Dr. Vincenzo Mirko Lafazia. First key finding is that during mapping of the pulmonary veins and posterior wall, electrogram quality was comparable between Sphere 9 and LASSO. Second, in areas outside of pulmonary veins and the posterior wall, LASSO produced EGMs with higher amplitude and more defined deflections than Sphere 9. Third, operators should be cautious interpreting Sphere 9 signals outside pulmonary veins and the posterior wall because they might differ from standard mapping catheters because of differences in electrode size spacing, catheter tissue contact, and local substrate characteristics. Next up is a paper titled Catheter Ablation versus Antiarrhythmic Drugs for Persistent Atrial Fibrillation and Hypertrophic Cardiomyopathy by Dr. Zaid Shahori and colleagues. First key finding is that catheter ablation was associated with significantly lower 12-month all-cause mortality compared with antiarrhythmic drug therapy in patients with hypertrophic cardiomyopathy and persistent atrial fibrillation. Second, catheter ablation significantly reduced heart failure exacerbations requiring intravenous diuretics, hospitalizations, and continued antiarrhythmic drug use versus antiarrhythmic drug therapy alone. Third, Kaplan-Meier survival analysis demonstrated higher survival probabilities in the catheter ablation group, 98.8%, than in the antiarrhythmic drug group, 96.5%, with a hazard ratio of 0.348. And finally, findings suggest that catheter ablation-based rhythm control may offer superior clinical outcomes compared with antiarrhythmic drug therapy in patients with hypertrophic cardiomyopathy and persistent atrial fibrillation, though prospective studies are needed to validate these results. The final paper is a research letter, and it is titled Comparative Analysis of Conduction System Pacing Learning Curves for Atrial Ventricular Block, a Single Operator Experience by Dr. Catalan Pastrella and colleagues. These authors conclude that in patients with AV block, his bundle pacing appears to have a shorter learning curve compared with left bundle branch area pacing when using a luminous lead. Well, with that, this ends the podcast for December. I hope that you enjoy all of these great papers, and Happy New Year, and we'll talk to you again in January.